Thank you so much, sir, and all the chairpersons. A big thanks to the BDCon organizing family for making me a part of this beautiful conference. I share my roots in the Eastern Coalfield area, so it's always fond memories coming back to this city. So moving on from the mesmerizing oration by Thomas, sir, my job is perhaps the opposite. Now we are talking about obesity, specifically managing childhood obesity. And when we talk of childhood obesity, we have a huge spectrum. I will be primarily restricting my presentation to exogenous obesity because syndromic obesity was already discussed in detail yesterday by Dr. Sunetra. So if you have to talk of an obese child, I think it would be incomplete if you don't look at the parents or the adults at large. So this is the data which we published from our center in 2019, so it's almost a 6-year-old data, where 5,300 odd patients who had walked into our center, whatever cause, maybe hypothyroid, diabetic, for anything and everything, we just meticulously record the anthropometry. What we found in West Delhi was that having a normal BMI are actually an endangered species. Hardly 13.7% people had normal BMI. BMI means a BMI between 18.5 to 23 kilograms per meter square. Almost everybody was overweight and obese. In fact, if you see a normal BMI people, in Delhi it is taken that you might be sick, you might be having some underlying illness. So people start questioning you. Obesity has been so normalized. Why it is important to see is perhaps because whenever we get to see obese child, at least I have never seen an obese child who doesn't have an obese parents. So if a childhood obesity comes to us, we make the child sit outside and talk to the parents. We tell them, unless you improve your diet and lifestyle, nothing great is going to happen. And it is the mother's satiety which decides how much the child ends up eating. Kids will say very fast, I am full, I don't want to eat. But unless the mother or the father is satisfied, they'll keep on feeding the child. And once you do it for months to years, the satiety point goes up, and that leads to the vicious propagation of obesity. So when we talk of childhood obesity, this is a systematic review which is under review for publication. We have to realize a childhood obesity has a history going back 2 generations, and the effects can be seen even ahead 2 generations. Here we try to look at we have low birth weight babies and macrosomic babies. So we try to look at what if the mothers were low birth weight or overweight when they were born, or fathers were low birth weight or overweight. Will it have an impact on their kids' birth 20, 30, 40 years down the lane? So surprisingly, we found that there are a lot of studies evaluating this. We analyzed data from 14 odd studies having more than 3,20,000 patients. And if you see here, adjusting for all the other factors, if the mother was born of low birth weight, she has nearly 2 times the chance of having a baby with low birth weight 30 years down the lane. And that would be a higher risk for also neonatal small for gestational age. Of course, the risk will be large for gestational age will be lower. On the other hand, mother who was born macrosomic would have 2.5 times of having a macrosomic baby 2 to 3 decades down the lane. So if a lady has GDM poorly controlled, she has a macrosomic child, we would see the effects even 2 generations down the lane. Is it even more? We don't even know. And what is interesting, we found that in terms of birth weights of parents to the progeny, the maternal link was stronger as compared to paternal. But suddenly we found an unexpected thing. Paternal but not maternal low birth weight was a better predictor of metabolic syndrome and diabetes in their future generation. So some genomic imprinting is coming into play, we really don't know. So I think we must realize when we talk of childhood obesity, we should look at the whole picture 2 generations back, and the impact can be seen even 2 generations down the lane also. Now when we look at Indian data on the prevalence of childhood obesity, this is IGMR paper, again published, not recent paper, almost 8 to 9 years back, which showed that 1 in 5 kids in India are obese. That's a pretty huge number. And 9 years down the lane, maybe it's even worse as of today, because if you see the graphs are going up. There is no sign of plateau also. That's the even dangerous part with regards to childhood obesity as compared to maybe diabetes or adult diabetes. So I'm sure now it may be even more. Talking of Delhi, the CAR study published from AIIMS showed that in Delhi, the prevalence of pre-diabetes is 50%. and the prevalence of type 2 diabetes is around 25 to 30%. The CARD study analyzed population-based data of Delhi, Chennai and Karachi, and so it's really, the most people don't even know it. The numbers are staggering and unbelievable. So I think we are also seeing more and more kids with type 2 diabetes, especially after the COVID pandemic, when sedentary lifestyle became so much more common, and the mobile phones and gadgets and technologies. Something which we never read in our medical school, kids in their end of first decade or early second decade of life coming with type 2 diabetes, frank acanthosis, skin tags, and it's really a sad story. So when we talk of diagnostic criteria, we cannot typically use the BMI cutoffs which we use for defining obesity and overweight in South Asians or adults. We have to use percentiles. I think we have to use weight, height and weight charts, and even easy to use is a BMI charts, I think. We have to realize anybody above 85th percentile is obese, anybody above 95th, overweight, sorry, 95th percentile is obese. And they have got severe obesity. When the BMI is more than 120th percentile for that age, we call it class 2 or severe obesity. And if the BMI is more than 140th percentile for that age, we call it class 3 or very severe obesity. The equivalent figures for adults would be like a BMI more than 40 or BMI more than 30 kilograms per meter square respectively. Again, when we look at a child with obesity, we always have to keep in mind syndromic obesity, which are a small number, but it's important to keep in mind. So as a rule, an obese child, an exogenous obese child would be tall. So the parents are happy, my kid is tall, he's doing well, a sign of affluence, good health. But these kids have puberty earlier, nearly 2 to 3 years earlier. So the epiphysis will fuse earlier and their final height will be compromised as compared to the peers who were of normal weight. So nothing to be happy of. Usually the obese kids are the tallest in the class, nothing to be happy of because their final height will be totally less or compromised. But if you come across an obese short child, that's a big red flag for syndromic obesity. So you should rule out hypothyroidism, you should rule out Cushing syndrome, and you should even think of syndromic obesities. There are other physical cues, the phenotype of the patient, the history of the patient, the vision, those histories, all the syndromic cause we should be taking. So as a simple rule is, a tall obese child, most likely we are dealing with exogenous obesity. A short obese child, very high likelihood of syndromic or endocrine cause of obesity in them.